bispecific antibody therapy, what you need to know. So my name's Liz, I'm one of the lymphoma care nurses, and we've also got Sharon, our CEO, here today as well. And we've got Kate from ALLG who will be speaking shortly too. So our mission at Lymphoma Australia is to raise awareness, give support and search for a cure. Holding sessions such as today helps ensure that we are able to provide education and support to our lymphoma patients and their loved ones, ensuring no one will ever face lymphoma or CLL alone. I'm just going to hand over to Kate from ALLG just to say a few words.
Thank you. So I just wanted to tell you a little bit about ALLG and who we are. We're the only not-for-profit collaborative blood cancer research group in Australia who are doing clinical trials for lymphoma and leukemia and myeloma and other blood cancers. So our group is made up of over 1,400 members at the moment across 98 sites across Australia and New Zealand. Many of your treating haematologists will be ALLG members, and our members are dedicated to our mission, which is to create better treatments and better lives for patients. So our work is about carrying out research to make sure that the treatments that are coming through not only provide safe and efficacious treatment, but also provide better quality of life as well. So we're not getting rid of, the things that are important to patients as well, and a trade-off for treatment too. So we will be here today. One of our researchers and our scientific advisory chair, Judith Trotman, will be speaking, and we also have one of our lovely doctor members as well, Janlyn, Falconer, who'll be talking to you about that. And we have a group of our team at the back. So if you are interested in learning more about the ALLG, we're very keen to include the patient voice in the research that we do, and we have a consumer representative panel, and we're very happy to have a chat to you about what that entails, but we'd love to hear from you about your experiences as well. So look forward to chatting with you all at the end. Thanks, Liz.
Thank you. So just some general housekeeping. So if you can, put your mobile phones to silent or off. Obviously be COVID safe, so we all kind of know that. Make the most of your attendance. So we do have a Q&A at the end with our 4 speakers. So we encourage you to save your questions for then. And we want lots of interaction and lots of good questions. So that would be great. We've got quite a bit of time allotted to that as well. Now, so we look forward to hearing from our 4 expert speakers today. So we've got haematologist Dr. Koon Lee, Dr. Janlyn Falconer and Professor Judith Trotman, and our nurse practitioner Karen Maddock. And we look forward to the insights and knowledge they'll provide on lymphoma care and treatment. And we might go to our first speaker. So we'd like to welcome Dr. Koon Lee up to the stage to discuss CAR T therapy. Dr. Lee is a clinical haematologist and CAR T-cell physician at Westmead Hospital. He's also a senior lecturer at Sydney University with research interest in T-cell therapies. Thank you, Dr. Lee. Mm-hmm.
Okay, thank you. Thanks, Liz, for the kind introduction, and thank you, Lymphoma Australia, for inviting me to speak in this event. It's lovely to see so many patients and families around for this event, and hopefully we can I can share some research insights into CAR T cells in lymphoma, which is, I think, one of the areas which is gaining a lot of prominence recently. So as Lee said, I'm one of the CAR T specialists at Westmead Hospital, and we are one of 2 centres in Sydney able to give CAR T cells currently, with another 2 more coming online very shortly. I've also dabble in some research as well, and my area of research also happens to be T-cell therapies and CAR T-cells, so I will hopefully share some of this with you as well. Okay, so without further ado, so now I just want to start by saying that lymphoma is a very diverse disease. I'm sure a lot of you in the audience will be familiar with this. Lymphoma can be divided into Hodgkin's and non-Hodgkin's lymphoma, and of course among the non-Hodgkin's lymphoma, which we'll be focusing more on today, there are different kind of categories as well, including the immature and the mature type of lymphomas, and again we are focusing more on the mature type of non-Hodgkin's lymphoma, and particularly the B-cell non-Hodgkin's lymphoma, which is what has been really been shown to be more targetable and treatable with CAR T cells therapy. So that will be what we will be focusing on. And even among B-cell mature non-Hodgkin's lymphoma, there are various different subtypes of B-cell non-Hodgkin's lymphoma, which some of you might recognize your subtype of lymphoma or the one of your loved one on the screen, and that includes the kind of the more indolent type on the left of the screen, the small B-cell lymphomas, or the kind of the more aggressive or larger cell B-cell lymphomas, which is kind of along the horizontal. And CAR T cells not available for every single of this indication, as we will come to in shortly in this presentation. Okay. So before we go on, I would like to draw your attention to this graph. Sorry, the resolution is not great, but what it shows here, this is Australian data, and this is showing that across the over the years, over the different decades, that this registry has shown, relative to a normal person or healthy person, how many percent of patients with lymphoma are still surviving. Of course, it's a very, very mixed basket of patients. They adopt all different kinds of lymphoma in this registry, but you can see that it's encouraging to see, from 1989 onwards until 2018, there's been a gradual kind of increase in the proportion of patients surviving with lymphoma compared to normal person, and that is up to about 80% at the last count. Hopefully with more treatments, we'll see that improve further. So to understand why we do CAR T cell treatment, I think it's first important to understand a little bit about tumor immunology, which is one of my favorite topics. So it is important to know that T cells, they are like the policeman in our body, and they kind of seek out all those infected cells and also those cells that's turned cancerous, and they go on to destroy them. And the way that they do it is either they can do it directly, or sometimes they rely on these dendritic cells, which I like to think of them as informers, or someone dobs on the cancerous cells, and then they go on to activate the T cells, the police cells, and then that goes on to actually destroy the cancer cells. Now, unfortunately, this whole process, even the best police system, does not capture every single criminal. And similarly, in patients with lymphoma and other cancers, it is one of the reasons is because of this breakdown of what we call the immune surveillance, and so that allows the cancer to take root and grow, unfortunately. And so what do we do about it? We can give chemotherapy, which of course a lot of you will be familiar with. We can give other kind of antibodies to try and target these cancers. But what I'm talking to you today is more about how to arm these T cells, or the policeman cells, to make them able to recognize these baddies again, to recognize the cancer cells again, and try and identify and destroy them. And the way that it is done is, by using a retroviral vector, which is basically a virus, to introduce genetic material into the T cells, and then changing the actual makeup of the T cells to allow them to have new ways of recognizing cancer cells. And what we call this will be CAR T cells, or chimeric antigen receptor T cells, which is the end product, and that is the gist behind the CAR T cells therapy. So CAR T cells, as opposed to normal T cells, they will have chimeric antigen receptors, which are little probes on the surfaces of the cells that are now able to recognize new antigens, which are basically flags on the cancer cells. And in the case of the B cell non-Hodgkin's lymphoma that a lot of you and all your loved ones have will be CD19, which is one of the flags that is actually present not only on lymphoma cells, but also on normal B lymphocytes as well, so normal immune cells. Some of the normal immune cells will also have this CD19 as well. So CAR T cells will then go on to destroy all the cells that actually have the CD19, whether they're lymphoma cells or they are kind of the cells that lymphoma cells arise from, which is the B lymphocytes. So that's the kind of the principle. So the I guess to allow CAR T cells to work properly, we need a good target, and CD19 is I guess the very definition of an excellent target for CAR T cells, because you have got a very, very high amount of this CD19 on the lymphoma cells usually. So high surface expression on tumor means that the surface of the tumor has a lot of CD19, and the target also needs to be relatively low in expression elsewhere, or only present in relatively dispensable tissue, which means only present in B cells. In this case, the B cells, getting rid of B cells does make patients more immunosuppressed. They will need to have replacement antibodies, but that's not the end of the world. We can always get donated antibodies and kind of maintain a good level of immunity in these patients, as opposed to other targets. Sometimes other targets are less dispensable. For instance, if the other flags are also present in the lungs or the heart, then those are much more dangerous. They can't really be used as targets for CAR T cells. It needs to be something that's only confined to a small proportion of cells. In this case, the CD19 is the best example, and the one that we have available at the moment. Okay, so what is this CAR then that we're putting into these T cells? Now, CAR is actually a chimeric antigen receptor. It's actually a chimera, which means taking a portion of the antibody. So the monoclonal antibody is derived from other animals like mice. We take those antibodies. We take the part of the antibody actually that can recognize human CD19, so a human flag. So these antibodies are able to recognize it, because our own immune system does not usually recognize part of our own body. So we need to rely on other species like mice and get this antibody, get the what we call the single chain variable fragment, which is the red part of the antibody, and then get that part of the molecule and link it to the what we call the activation domain of the T cell receptor. T cell receptor are the kind of what we call those are the action native receptors of T cells. So that's usually the way that T cells recognize and activate themselves when they recognize a cancer cell. The T cell receptor is what usually gets activated. So if we take the part of the antibody that's able to recognize CD19 and link it with the part of the protein that usually gets activated when the T cell receptor engages with the target, then it appears that this construct, which is a very kind of a very strange construct, appears to be able to do the job. And when they are now put into T cells, these T cells can now become activated when they get into contact with CD19, which is the flag. So I guess when the first time I hear about this, I was a little bit surprised that this will actually work, but actually it does work very well. Okay, so then the whole process, the logistics of how to do it then is, usually it's an autologous process, meaning comes from the patient themselves usually. So the T cells are harvested or collected from the patients by putting them on an apheresis machine. You get put on a machine, almost like a dialysis machine, for about 6 hours, and then some of you would have had stem cell collections. That will be the same kind of process. The T cells are collected with that machine. They are sent away to certain centers to manufacture the CAR T cells. It might be to Singapore or to America or to Melbourne, centrally to manufacture those T cells. That whole process of modifying these T cells and expanding them to enough numbers take about 3 to 4 weeks on average, and during that time, the patient, which is going along the step number 3, will be given more chemotherapy or radiotherapy to try to control the lymphoma. And then given some other chemotherapy perhaps to get rid of competition. When we reintroduce the CAR T cells, we want to make sure that there's no other kind of other lymphocytes around, that are very minimal other lymphocytes around, so that the CAR T cells can actually work the best to try to do their job properly. So that's when step number 5 is where, after you get the CAR T cells, you stay in a hospital, in either Westmead or RPA hospital in New South Wales, and you'll be staying there for about 10 days at least. And of course, that's to monitor for any kind of complications that can happen. And after that, you'll be still asked to live quite close to the hospital, because other side effects can happen further down the track. I won't be talking too much about the dark side of CAR T cells. It'll be I'll leave it to our nurse practitioner Karen Maddock, who will have to talk about that side of things. So I get to talk about the good things, and Karen gets to tell you about the side effects. Okay, so moving on to the next part of this, I guess. So a lot of you will be asking, can I get these CAR T cells now? And so the answer to that is really, I think, it depends on which part of the process we are at with the approval. So it takes a long time to go from discovery and I guess preclinical development of a drug to having to go through clinical trials, and then getting it registered with the Therapeutic Goods Authority, and then getting the Medical Services of Australia to approve it, and then further to that, needing to get it all set up in a hospital. It all takes many years, this process. So right now in Australia, we have a few approved indications for CAR T cells, and this for lymphoma. This includes the diffuse large B-cell lymphoma and related kind of aggressive lymphomas up in number 1. So if you or your loved ones have had 2 prior lines of chemotherapy and not had a satisfactory response, and or if you have relapsed after an autologous stem cell transplant, or if after the first line of treatment you have not responded, or have the disease has come back within the year of treatment, then you would be able to access this treatment with the funding by the MSAC. So the second indication is mantle cell lymphoma, and mantle cell lymphoma, you would have needed to have had at least 2 lines of treatment, including one containing chemotherapy and one containing these tablets called the BTK inhibitor, or Bruton tyrosine kinase inhibitors. And if you failed these 2 types of treatment, then CAR T cells are available through this government funding. And of course, the third indication is that of B acute lymphoblastic leukemia or lymphoma. This includes patients who have actually relapsed early or relapsed following 2 prior treatments. So I think that was more from the disease perspective, but also because CAR T cells, they can be quite difficult to tolerate, because if you imagine you are having a very kind of directed therapy, allowing this super strong T cells to attack lymphoma very, very aggressively. It can have a lot of side effects, which Karen will detail later. But then that also means that we need to have certain kind of criteria, or like certain kind of guiding principles behind who is suitable for CAR T cell and who is not suitable for CAR T cells, because you need to have the kind of the physiological reserve to be able to tolerate this strong treatment. So first of all, of course, you need to have the lymphoma needs to have the target that we are actually proposing this targeted treatment for, which is the CD19 in this case. And also, of course, the disease can't be too quick that you can't produce the CAR T cells in time. It takes 3 to 4 weeks to be able to make those CAR T cells, so we have to have the confidence that it is possible to actually have this time for these things to be manufactured. Of course, the organ function reserve, as you can see here, the kidneys, the heart, and the lungs are the main organs. And of course, patients with other active malignancies or with low life expectancies, unfortunately, because of the cost of the treatment, the government has to draw a line somewhere, and that it does cost upwards of a few $100,000 for each dose of treatment. So that's because of that reason, it needs to be judicious in terms of who we give it to. And the last one is social support, and because of the side effects that can happen, we usually require that there is a loved one or someone who is able to provide 24 hours a day supervision in the 1 month after the treatment, because there will be there might be side effects that come up during that time, which requires the presence of another responsible adult to be able to deal with those side effects. Okay. So I've move on to diffuse large B-cell lymphoma, which is the most common indication for CAR T cells at our center. So diffuse large B-cell lymphoma, we know that CAR T cells work very well in the third line. But I guess how did we get to this is that, diffuse large B-cell lymphoma responds very well to the upfront treatment, which a lot of you would have heard is the R-CHOP chemotherapy. About half the patients or more will get cured with just R-CHOP chemotherapy alone. But the problem then comes when it relapses after R-CHOP chemotherapy. As you can see, this publication from 2011, the authors were were just commenting that actually for patients who is relapsed after the initial treatment with R-CHOP chemotherapy, the outcomes are not that great. I mean, only about 10% of the patients actually get cured with standard therapy, and that's really quite abysmal. And I guess the good thing is it's been shown that CAR T treatment given in the third line or later, we have the ability to cure about 40+% of patients. Not great, but I think that's a significant improvement from about 10%. So, but then the next question comes, will be, can we do better if we give CAR T cells even earlier than third line of treatment? This is where we have got this trial, which is called the ZUMA-7 study. This was looking at patients who were able to have an autologous stem cell transplant. So the study actually asked the question, can the patients do better if they get CAR T cells treatment first? I'm trying to do this. Okay, so which is axi-cell, which is the CAR T cell. Or would they still do just as well if they went through the standard care of salvage chemotherapy and autologous transplant? And if they then don't do well, they are still allowed to get CAR T cells. So they'll go back to that route, but then they would have to try that first. So this is, I guess, an important study to answer the question as to whether CAR T cells are actually good even in the second line setting, meaning patients who's just failed R-CHOP like within 12 months or not responded at all to R-CHOP chemotherapy. So is this going to improve on the current standard of care at that time, which was autologous transplant? Okay, so, and I don't know whether any of you are familiar. This is the Kaplan-Meier curve, which basically is saying what is the proportion of patients surviving at a certain time point. So here they start off at 100%, meaning all the patients are surviving initially. But as time goes on, some patients unfortunately pass away as a result of the disease or other complications from the treatment. And here the blue line are the patients assigned to receive CAR T cells up front, and the pink line here are the patients who are assigned to receive transplant up front, and some of them actually went on after they failed transplant to CAR T cells to get CAR T cells after that. And I guess it is very kind of interesting to note that despite them being able to access CAR T cells later, these patients actually, on average, those people getting CAR T cells at the second line, meaning earlier, they seem to do better than patients who end up, on the standard of care, which is the transplant arm. So I guess this is a really, really kind of practice-changing study, which is also why last Christmas we were able to get approval from the government to be able to give CAR T cells to patients with diffuse large B-cell lymphoma who are, in their second line, having failed the first line treatment completely or having relapsed within 1 year of the treatment. So that's, all these are all based on evidence, and, that's the reason. Okay, so then we come to mantle cell lymphoma. Again, this is based on this ZUMA-2 study, which is a study to look at patients who's had exposure to one line of chemotherapy and at least one type of Bruton tyrosine kinase inhibitor, which is something like ibrutinib, acalabrutinib, or zanubrutinib. So these patients on the will get CAR T cells. It was a single arm study, meaning that it was all the patients got CAR T cell. In this case, it's called Tecartus. So all the patients got CAR T cells, and you can see that the overall response rate was very, very kind of promising at 93%, including 2/3 of patients going into complete remission. And 43% are still in remission for more than 2 years after follow-up. Now you might wonder, is this good? Is this bad? How do we know whether this is good or bad? Because we need to compare it with something to know whether this is better or this is worthwhile pursuing. And so the authors of this trial went on to compare it with historical matched data, and you can see here, these are patients who get other treatments, so similar patients who's had at least two lines of treatment for mantle cell lymphoma, and this proportion surviving, they drop down quite rapidly, down to less than 10% within 4 years. This scale is different. This is 3 years here. But you can see that the proportion of patients surviving are definitely, looking like a lot better compared to the other option. So that's also the reason why we got approval last year to be able to give CAR T cells for mantle cell lymphoma. Okay. So I'm not going to go through every single indication. So I guess the question really is what do we think is coming next? What are the next caps of the rank in terms of CAR T cells? What are the indications are we pursuing? One very kind of interesting one is follicular lymphoma. Now, follicular lymphoma is one of the more kind of indolent and low-grade lymphoma, and patients can live for many years with follicular lymphoma, but sometimes they can behave in a more aggressive manner as well. So some of patients, they do unfortunately run out of treatment options, and so there are a couple of trials focusing on this particular indication, including this is T-cell study, ELARA study for Kymriah, which is a type of CAR T cells against CD19, and you can see that a lot of patients are surviving for a long time after they've run out of other options after being treated with this type of CAR T cell therapy. Again, where is the comparator? Well, how do we know that this is better than comparison? They don't have a comparator on this study, but they do have one for the other CAR T cell, which is the Yescarta, which is the Zuma 5 study. Now again, they have resorted to using historical comparison. And you can see here clearly the group of patients receiving the CAR T cells for follicular lymphoma appear to do better than their counterparts who have been given other treatments. So I think this is one to watch, and it's already approved in the States under FDA approval. They've already approved it. Is it coming to Australia soon? I hope we can find the funding to support that, and I guess a lot of that boils down to the quality of life, years added, and all those kind of and whether or not there is resources for that. I certainly think that if there is resources, this will be one to pursue. Although there of course are the treatments for follicular lymphoma as well, which you'll hear from Dr. Falconer later as well. Other studies, ALLG trials included. We're trying to push the envelope a little bit with CAR T cells. Can we treat it for other types of lymphoma, or just that few types of lymphoma that I've already presented? Certainly, there's one here. Prof. Maher Gandhi, working out from Queensland, has this study which is been open for some time, but they've opened and closed for different types of lymphoma. They're trying to use anti-CD19 CAR T cells for various more aggressive or earlier lines of treatment, trying to see whether or not it could be suitable for more patient groups. And as with clinical trials, as you hear from Professor Judith Trotman later, is those studies, they do open and close very quickly, and it's always very important to keep our fingers on the pulse to know when they are available for our patients. And this other one here, which is the brain CAR, I think Westmead Hospital is a site for that as well. It's opening soon. It's about primary CNS lymphoma. It's currently primary CNS lymphoma is not one of the approved indication for CAR T cells, but we think that it will be quite effective in the lymphoma, which is just in the brain alone. But of course, it needs to be proven in clinical trials, and so that is coming soon to Westmead as well as a site. Okay, and other CAR T cells. This is CD19 is not the only target, so we have other targets for CAR T cells as well, because CD22, which is another flag or another surface marker, which is very, very common in a lot of B cells lymphoma. So these are all trial data. This is from a Lancet paper last year for patients who failed CAR T cells with CD19 or the standard CAR T cells. If they failed that, these patients are given another CAR T cell against a different target. So we're kind of rearming the T cells to try to attack something else. And it's great to see that the 2/3 of patients actually still respond, including half of them having a complete response, and those who actually have a complete response, they actually so a lot of them actually survive for 3 years or more. So I think this is exciting, and right now we are able to to cure 40-50% of patients with CAR T cells against CD19. But if we get another bite at the cherry, that would be wonderful news. And of course, there are other things like bispecifics, which Dr. Falconer will talk about, which will also provide another bite at the cherry. Okay, so what about T-cell lymphoma? I don't know whether or not anyone in the room or any of your loved ones have got T-cell lymphoma. They are a bit rarer, but the T-cell lymphomas, unfortunately, they are can be a lot more aggressive. The survival outcomes tend to be worse. These are T-cell lymphomas, and these are B-cell lymphomas. The survival outcomes tend to be worse across the board for T-cell lymphomas compared to B-cell lymphomas, and even in leukemias as well. Those with T-cell leukemias, they do worse than B-cell leukemias. So do we have anything in the future for these patients? I think there are some difficulties in trying to do that, because T-cell lymphomas, they arise from T cells, and if we are trying to use T cells to attack T-cell lymphomas, there will be problems because, you could end up with a target that's also present on the CAR T cells, and the CAR T cells might end up killing each other instead of killing the T cell lymphomas. So fratricide is what we term that phenomenon. You could end up killing a lot of good T cells. You kill the good policemen, so T cell aplasia. So you can run into trouble with a lot of problems with your immunity, much worse than when you target B cells. And of course, sometimes when you're trying to make CAR T cells, you might get the T cells which are actually lymphoma cells, and you make them CAR T cells, they end up becoming immortal. So you have malignant contamination. That's not a good outcome. So it's more challenging to say the least with T cell lymphomas. So that's not to say there's nobody trying. There are lots of people, lots of groups trying to do this CAR T cells for T cell lymphomas. For instance, I've just taken one study. This is overseas in China. How they have done it is they have done CAR T cells against this thing called CD7, which is a marker, a flag on T cells. But to prevent the CAR T cells from killing each other, they actually did genetic engineering on the T cells themselves, and they do a knockout, meaning they kind of deleted the CD7 on the CAR T cells themselves. So you get rid of the ability of the CAR T cells to kill each other, because it appears that the T cells can actually still survive without this CD7 marker. So if you make these CAR T cells able to recognize CD7, which is the flag, but at the same time get rid of those flags from the CAR T cells themselves, it seems like this might work in this study. And at the same time, they have done all other kind of modifications, including knocking out the T cell receptor and knocking out a few other things to make them able to be off the shelf, meaning that any person can actually donate their T cells to the patients, not necessarily needing to come from the patient themselves. So I think it's a very, very kind of ambitious trial. As you can see here, small number of patients were treated. Some of them got, this blue means they're still surviving. Some of them got good outcomes. So I think it's all very, very kind of promising, but I think, it's not available right now. Might come to our shores probably, I would say, 5-10 years, I would hazard a guess. So so that's certainly something, work in progress. And CAR T cells, as I said before, is just one of the many different things happening in the lymphoma space. We have bispecific antibodies, which Dr. Falconer will talk about, and we got this, what we call the ADCs, which is antibody drug conjugates, which are also very, very promising. And then we've got other small molecule combinations that we are also interested in, and some of them are ALLG studies as well. So certainly a lot of things happening in the lymphoma space. I want to end with this slide again, and I think we're seeing improvement year on year, and I hope that with all these new advances, we will continue to see this. The next time I give this talk, I'm hoping that we'll have a much better number than this time around. And so with this, I thank you for your attention, and this is the team at Westmead. And happy to take any questions at the end.
Thank you, Dr. Lee, for that very informative talk. So we'd now like to welcome our second speaker up the front, Dr. Janlyn Falconer, to discuss bispecific antibodies. Janlyn is a staff specialist haematologist at Concord Repatriation Hospital. Janlyn maintains a strong commitment to education and clinical research with particular interest in lymphoma and cellular therapies. Thank you, Janlyn.
Brilliant. Well, thank you to Lymphoma Australia, thanks to ALLG, and welcome to all of you. We really appreciate you all being here today. And lovely Koon and I trained together many years ago, so I'm so proud as friend and colleague to see him doing incredible work at the cutting edge of CAR T-cell therapy, so thank you, Koon. Now, fortunately, he's also set the scene beautifully in terms of giving a bit of an overview about our immune system, and so I won't have to rehash any of that information and dive straight into talking a bit about bispecific antibodies. So as you'll recall, Koon talking about those T cells, the chiefs of our immune system, there are some similarities you'll see when we talk about how these bispecific antibodies work when compared to CAR T cell therapy. So when we think about bispecific antibodies, what they indeed are is immunotherapy treatment that's designed to recognize two different targets expressed on the surface of cells that we refer to as antigens. So if you think of them a bit like team caps, different colors, you know how to identify which cells are which. And these antibodies then attach to the receptors on both the surface of the T cell, which you can see, do I have a little pointer? Oh, I do. On the surface here, you can see the T cell on this side with typical CD3, which is one of the surface markers, and an example here with a lymphoma cell attaching to this tumor antigen. And what it basically does then is able to bring those two cells into close proximity. And what that does is stirs up a whole lot of cytokines, which are basically communication proteins. It gets some of the other inflammatory or immune cells involved. And if you think a bit of these two cells, a bit like boxers heading towards each other the way in, the closer they get, the more the pheromones flow, the more likely you are to have fisticuffs. So essentially by bringing these two cells together, you activate those T cells to send off these proteins, to bring in the reinforcements, and to get busy killing off those cancer cells. So just looking again at a specific example of a bispecific antibody working in lymphoma, which will be the focus of today's talk. Down the bottom here, and apologise, it's probably slightly teeny-weeny writing for you guys on the screen there, but down the bottom are 4 of the most common bispecific antibodies that have been utilised recently in clinical trials and studies across a host of different types of lymphoma. And again, just that example there of the bispecific antibody bringing the T cell together close to this lymphoma cell. And you'll recall that Koon spoke about CD19 being one of the markers on the surface of a B cell, a lymphoma cell. CD20 is another one of those, and so bispecific antibodies can target a slightly different receptor on the surface, bring those into close proximity, and get things working to kill off those cancer cells by stimulating that immune system into overdrive. It then causes expansion of extra T cells and chiefs to start bringing in extra recruits, and the aim is, of course, resulting in cell death of those cancer cells. So, important question, how are these treatments administered? We've heard about the sort of life cycle of how CAR T cells are manufactured using people's own cells. These bispecific antibodies are essentially what we call off-the-shelf treatments. In other words, they're manufactured independent of somebody's own cells, but they're usually administered by one of 2 routes, either subcutaneously via an injection under the skin, usually in the abdomen, or in an intravenous infusion. Now, depending on which type of bispecific antibody, some are utilised, and the way the clinical trials have been set up, from initiation all the way through until either you're not tolerating them anymore or there's progression of the underlying disease. But some have been studied looking specifically at what we call fixed duration therapy. So often 12 months of treatment and then call it a day. So this is just a little bit of an overview, and already a paper from 2024, there's been lots of changes since then, just giving you a bit of an overview and an understanding of the amount of activity in this area of research. So looking across here, again, these are the 4 most common bispecific antibodies being utilised in lymphoma. And here you've got examples of follicular lymphoma, diffuse large B-cell lymphoma, and mantle cell lymphoma, which you've heard Koon refer to already today, and different phases of clinical trials. So phase 1 meaning we need to check if they're safe, and if they are, they move on to phase 2, do they work well? And if they work well, we move them into phase 3 studies, and that is comparing them with the current standard of care to see, do they actually work better? Because what we know and why clinical trials are so important is just because something's new doesn't automatically mean it's better than what we're using at the moment. So we need to know that for sure. Bispecific antibodies, as I said, the focus really today is looking at lymphoma, but important to know that they have broad application across a number of different hematological cancers. So in particular, multiple myeloma, some leukemias, and some really exciting new clinical trials using new targets. This is just a quick preview to highlight again, same idea, using a bispecific antibody. This is in patients with myeloma, the same T cell and antigen, but here you can see it's a different target, different cell, different target. And this, I guess, is just a way of having a little bit of a bird's eye view. Again, this will already be a little behind the times by the time it was published, but looking at the vast number of different antibodies that are in production. You can tell some of them still just have numbers, not names. You'll recognise some here like mosunetuzumab, glofitamab, which are used in lymphoma, but there are also antibodies being developed for diseases in solid organ tumours and for other indications. So it really has a broad potential use across a number of different diseases. And this is just a really beautiful picture looking right down at the cell level. This was taken from the MD Anderson Cancer Center in Texas, looking at, again, that cell, the other target cell, and how that bispecific antibody brings those two in close proximity. So quite beautiful when we look down the microscope. Now, the next question is, that's all fine and good, that sounds a bit exciting, but do they work? So this is just a little bit of a diagram illustrating, again, a bit of a bird's eye view about lymphoma in general. So you'll start to recognize these names here again: mosunetuzumab, glofitamab, epcoritamab, and odronextamab, with a couple of extra little hangers on at the end. If we look up the top here, blue represents aggressive or faster growing types of non-Hodgkin lymphoma. So those would be things like diffuse large B-cell lymphoma. The green represents indolent or more slow-growing lymphomas. The best example of that is follicular lymphoma, which is the most common indolent lymphoma. And you can see here, looking at each of those individual antibodies, the lighter green stands for patients who've had at least a partial response, so about 50% improvement in their lumps and bumps lymph nodes or disease, and the darker green, a complete response, and the same when it comes to the blue colours. Now, what you will see is, overall, actually, those patients with indolent lymphoma seem to respond really well across the board. The blue over here in the middle specifies that these two antibodies are indeed the two that have been used most frequently in more aggressive types of lymphoma, really based on, when we looked at them, they seem to work better. So some of these have been evolving in terms of their indications and are utilised more in the slower growing lymphomas, some more in our faster growing lymphomas. Now, we know they work, that's great, and there's good efficacy, but also what is the toxicity associated with some of these treatments? And again, down the bottom here, when we think about side effects related to treatment, we doctors grade these, basically to work out how severe they are. So grade 1 to 2, which is demonstrated here by these sort of light salmon-y coloured bars, really shows us that the majority of toxicity associated with these treatments tends to be lower grade, so usually less serious, but that's not to say that there is a smattering here of some higher grade toxicities. And we'll talk a little bit more about what those are, and wonderful Karen is going to outline those in more detail for us as well. So those toxicities, there are a couple of important ones to know about in these immune type therapies. Most prevalent really in CAR T-cell therapy, but very similar in bispecific antibodies. And the first of those is CRS, or cytokine release syndrome. So you'll remember from that first picture with those little cytokines springing into action when the cells were in close proximity to one another. Those are those small proteins that let your body know when there's an immune response that's needed. And they play that important part in communication between cells, particularly when the body's under stress. So in times of inflammation, infection, or indeed trauma. And cytokine release syndrome is really an inflammatory reaction that affects the whole body. And so the typical symptoms that are associated with this syndrome are, number one, fever, which is the most common, and you need it to actually call it CRS. The other important factors are a drop in blood pressure, and really that's because those cytokines cause a little bit of that inflammatory response, dilation of our blood vessels, a drop therefore in our blood pressure as we have high fevers, sometimes difficulty breathing as our lungs can get a bit congested with all the fluid and inflammation going on. Sometimes people can feel fatigued, nauseous, have a rapid heart rate. And whilst, as I said, with bispecific antibodies, most of these toxicities are of lower grade, so sometimes can just precipitate in a fever. They can and have the potential to be more serious, and we'll talk a little bit about some of the treatments, and Karen will outline a little bit in more detail. ICANS is essentially the neurological side of things, so it's an immune effector cell-associated neurotoxicity syndrome. And really, again, related to those inflammatory cytokines, but in this instance, affecting the brain. And so in its mild form, can present with just a headache or feeling a bit off colour, perhaps not quite as sharp as someone normally feels. Occasionally patients I've looked after just been a bit grumpier than they normally are, which is out of character. But certainly as things progress or become more serious, this can present with confusion, weakness, and in more severe cases, seizure and even coma. And that's certainly why we often keep a really close eye on these people, particularly in the case of CAR T-cell therapy, where patients are admitted for that early part of their treatment, but also in bispecific antibodies, where we've learned over time and through clinical trials what medications to use to try to mitigate some of those symptoms. Infection is, again, one that's an important one to mention. And, Koon touched on really nicely the role of some of these cells in our immune system. And the B cells, whilst we're talking about non-Hodgkin B-cell lymphoma, are the cells affected by our disease, they're also the cells that help to manufacture our immune proteins that help our body to fight off infection. So whilst it's great that these targeted therapies are so good at getting rid of these disease B cells, they do such a good job that they suppress almost all of those B cells. And what that results in is low immune proteins or antibodies in our system, and it can make us much more vulnerable to infections, and not necessarily just garden variety infections, but sometimes the more weird and wonderful. And so that's why close monitoring, prevention, medications to help prevent infections is so important in the state of this therapy. So again, apologies for the small writing, but this is just to give a bit of an example about further efficacy in the setting of follicular lymphoma when we use these antibodies on their own. So this is pretty early data, but you can see when ORR here refers to overall response rate. So you can see when patients are exposed to these medications, often in the setting of having relapsed or refractory disease, so may have had multiple lines of treatment beforehand, they still have a really good overall response rate to these treatments. And in terms of toxicity, this is just to highlight that whilst there certainly is cytokine release syndrome, particularly in these early trials when we were still getting good at mitigating and treating those side effects, the vast majority of it was lower grade. Now, at the moment we've spoken a little bit about monotherapy, in other words, just using those antibodies on their own to treat these lymphomas. But what's also really exciting is the advent of combining these antibodies with other types of established treatments, such as chemotherapy. And these are just a couple of examples of combinations of a bispecific antibody, here epcoritamab and here glofitamab, combined with a chemotherapy backbone. So in this case, gemcitabine and oxaliplatin, which was one of our common go-to chemotherapy combinations that we would use in people who had relapsed diffuse large B-cell lymphoma. And what's really interesting is that when we combine the antibodies with chemotherapy, not only do they make the treatment more effective, but also there doesn't appear to be a significant increase in the amount of toxicity. And obviously that's really important. Whenever we're considering potential treatments for patients, we always think, number one, yes, we want it to work well, but also we want to continue to work on minimizing toxicity for people. So this study here, there were several Australian sites, and one of our colleagues was heavily involved in this study here called StarGlow. So some really exciting data for patients with relapsed and refractory disease, but there are also several trials currently underway, or even recruiting, I think finishing recruiting in some parts of the world, where we're looking at moving those therapies earlier on. So utilizing a combination of bispecific antibodies and chemotherapy for people with newly diagnosed diffuse large B-cell lymphoma. And here again, small writing, but just to show you the amount of activity in this area. This is again combining bispecific antibodies, here glofitamab and mosunetuzumab and epcoritamab, odronextamab down the bottom, with a number of different treatments, be they chemotherapy, other types of immune therapies, and in all different subtypes of lymphoma and in different lines of therapy, so for newly diagnosed disease as well as relapsed refractory disease. So a really exciting time for research, lots of very interesting things in the pipeline. One of the important things we think about when we are considering the best treatments for people is the issue of time toxicity. And if there are people in the room today who have been through that treatment journey themselves, you'll be very familiar with the travel time to hospital, the waiting time both for treatment and in clinic when you're coming to see us, hospitalizations if you're needing to have observation or indeed treatment for any types of side effects. So we're very mindful of all of those things. And that leads in nicely when we're thinking about the different contrasts with these types of immune therapy and some of the logistics. We're also pretty practical when we think about this. So as we mentioned, bispecific antibodies are that off-the-shelf treatment. They don't need your cells to make them, but just because they're off the shelf doesn't mean they're utilised at full dose straight away. We often have ramp-up dosing where we give smaller bits first and increasing in dose over a course of 2 or 3 weeks. And that's really to acclimatise your body and your immune system to these treatments to minimise the chance of reactions or side effects. Obviously, contrasting that to CAR Ts, where you have your referral to go and see your specialist, have the cells phoresed and manufactured, and then returned to you, and they go in all at one go, and it's a sort of a one-stop shop. Those bispecific antibodies, we spoke about the methods of administration, often have lower rates of those important immune toxicities than CAR T cell, but important to consider and to look out for, and really exciting that there's ongoing research in terms of combinations. So essentially, I think what I'm trying to get across here is both are excellent treatments, and really it then comes down to speaking with you as a patient, or if you're a family member of somebody here today, what is best for you as an individual. And when we think about that, some important questions we ask, and certainly hope you're asking us as well, is what is my diagnosis? What subtype of lymphoma do I have? And are there any important characteristics of my disease? How fast is it growing? Do I have lumps and bumps if I've got fast-growing lymphoma that are pushing on important bits of my body? Do I need to get going with treatment really quickly? And often that helps us to know which path may be best to go down. Other important information is your background medical history, so any significant other issues you may have that might have implications in terms of what therapy could be best for you. The disease status, so is this your first time, a new diagnosis with treatment? Have you had other lines of treatment beforehand, and what were they? Because that helps us to know what treatment you may be eligible for, both as a standard of care, and Koon beautifully outlined what the standard of care treatment options are for CAR T-cell therapy and lymphoma in Australia at present, but also really importantly in the setting of clinical trials. So we're all here at the ALLG today. We're all passionate about clinical research and partnering with patients in that clinical research. It's so important in terms of not only being able to get access sometimes to these therapies before they are formally approved and get all the way through clinical trials, but also because that's such valuable information informing those future decisions and future patients as well. But really I'd emphasise here that shared decision making with your doctor. Part of that discussion also involves a little bit of strategy. So I often use the analogy of a bit of a chess game. As we've had some of these new therapies evolving, there are more pieces on the chessboard. And knowing and thinking ahead in terms of what might be right for you right now, what might be around the corner, thinking carefully and planning so that you get the very best treatment along the way and have strategies for the future as well is so important. And so all of that feeds into those important discussions we have with you as your clinician. So that's just a little bit of an overview. We look forward to some interesting questions, but I'll let Karen come and give us the really important information.
Thank you, Janlyn, for that in-depth discussion. So please welcome our next speaker, Karen Maddock, to the stage. Bringing over 30 years of experience in haematology, she began her role as the haematology clinical nurse consultant at Westmead Hospital in 2007 and remains at Westmead in her current position of cell therapy nurse practitioner. Karen will be discussing CAR T treatments and logistics.
Thank you very much for having me today. Thank you to Lymphoma Australia for asking me to speak. Hopefully I'll be good coming after those two wonderful speakers. Right, so now we're going to have a whirlwind ride through this because I've only got 30 minutes to take you through this. So hopefully there'll be lots of questions I can answer afterwards. So basically the patient pathway that I'll present today, we've already talked about being referred to the CAR T-cell centre, collection of lymphocytes, we'll go through a little bit about apheresis again, manufacturing of the CAR T-cells, bridging therapy, lymphodepletion, administration of the CAR T-cells, some of the common toxicities, I don't have time to talk about them all, but we'll go through some common ones, and then a little bit about follow-up. So this is based on our Westmead experience, so You'll be referred from wherever it is that you are to Westmead. Contact with the CAR T-cell team is really important. That happens straight away. You'll have a lot of contact with our clinical nurse consultant. She's the one that organises all the appointments. Now, normally the first appointment is within a week, and sometimes it might be if there's a lot of aggressive disease around. Somebody might ring us from Canberra and say, look, I'm really worried about this patient, and quite often Koon might see them the next day. So it's a bit of a whirlwind to get up to Westmead. I think the big thing that I need to let you all know that if you're coming from all over the place, we are able to provide accommodation. So you won't have to have that extra expense of paying when you come to Westmead or to RPA for your CAR T-cell therapy. The companies provide assistance with travel, and they also provide assistance with staying in local hotels up until day 30 after the CAR T-cells. And that happens for when you're coming down to be reviewed as well. So if you've been seen, we have a little bit of a local MDT go through all of the patient either disease, toxicity management, and if you've got any comorbidities, so we talk about that. And then if our hospital accepts, then we on a Tuesday morning talk at the National MDT. So every CAR T-cell centre around Australia dials into that, and there's quite a robust conversation sometimes about who's eligible, who's not eligible, how we're going to bridge people, what are we planning to do with toxicity. So there's all of these amazing brain trust together and work out a plan for each patient. Then we talk about apheresis, and then plus or minus bridging therapy. Some people may not need it if their disease is not really aggressive, but others might. And then we have pre-admission workup where you'll talk to the coordinator, and I'll go through a little bit about that later. Day -6, we start. Most of our people have ambulatory care, so it'll be as an outpatient, and you'll have your last time out to make sure everything's in order. We've done all the right tests. We've checked you for viruses. You haven't got COVID. You haven't got RSV. All those other viruses that we would not like to go into CAR T-cell therapy with. And then you can start day -5 to day -3, come into the cancer daycare centre. Some people, if they are a little bit older or the comorbidities are a little bit concerning, or there's a lot of disease and we're concerned about tumour lysis syndrome, we might bring you into hospital for this time. Then there's a couple of rest days and admission to the ward on that. And then day 0 is a CAR T-cell infusion day. Most people will be admitted for about 10 to 15 days, and that's sort of standard across the world. And then you're discharged into an ambulatory care setting again. And at Westmead, you would see me 1 or 2 times a week, and then Dr. Lee or one of our other haematologists on the other day, up until day 30, when you're either having a PET, plus or minus a bone marrow biopsy, or sometimes if people have disease in their brain, then they might need to have an MRI of the brain as well, and then transfer back to your centre. So, as I said, patients are seen very quickly and discussed at the national meeting. So venous access when you come is very important, and most of you, if you've had treatment before, know what it's like. We're digging around looking for veins. So we need to make sure that you've got 2 really good veins in your arms to collect the cells from. If you haven't, then we will be looking at other options like central lines. Then we book an apheresis slot, and that really depends on the product when we can get a slot, but normally that's within a week. And then depending on when you had your last dose of steroids or your last dose of chemotherapy or radiotherapy as well. So if you've just had some treatment, we might need to wait for a washout period, and I'll talk a little bit about that one later. So here, this is if you've got good veins in your arms, this is what it will look like: a vein and a needle in each arm, and then that's the apheresis machine there. However, some people need to have a central line, and so we would do a tunnelled catheter. This part is in under the skin. There's a little cut just over the clavicle there, so that the line is inserted down into one of the major vessels just before the entry to your heart. This is a chest x-ray which shows it really well, and that's the heart down there, and you can see that's the tip. So it's in a big vessel. It means that we can do the apheresis, which takes a lot of pressure to pull all that blood off and put it back in. And then we can give chemotherapy through that, and we could give 2 different jugs at the same time that would not be compatible because it's a big volume there. They're not going to meet, and so we can give them at the same time. Very good also if we needed to give fluid resuscitation. If we needed to give you a lot of fluids very quickly, then we can do it through these lines. So this line can stay in for apheresis, for the chemotherapy bridging, and then for the CAR T cells, and then we will take it out afterwards. Yeah, I was thinking, I was wondering that. Yeah, that's better, isn't it? Yeah, so that's where you can see the heart down there, so just at the entrance there. And so there's another photo there of central line. That's the exit site there, and you can see the blood's been taken out and then put back in that side. Removed from one arm, spun through the machine. We collect the whole blood. The lymphocytes are collected in a bag out the side, and then the blood is put back in to the other vein or the other side. So this is an apheresis machine. So coming out the side, that's your CAR T cells being collected there. Might need a little bit of electrolyte replacement while you're on the machine, and a blood warmer there, and then coming back in. Janlyn and Koon have already been through this, but I'll just a quick run through again. So we're going to take the cells off. They're sent overseas for manufacturing. That means that they isolate and activate the T cells. So when they're activating, they can then put the CAR in. So Koon gave you a wonderful explanation before, so I'm not going to go over that too much, but here is our targeting element, and it's the CD19. So you can see that on the top of the CAR T cell. Then once they've made these, they then expand them because we need to manufacture quite a lot of, as you can imagine. And then over this period of time, manufacturing is normally about 17 to 28 days, depending on which company we're having to use. And then patients may or may not undergo bridging therapy then. And then we're admitting you, giving the CAR T cells, and then we wait for the activity. So washout period, that means the time, and our washout period can be either before the apheresis or before you have your CAR T cells. And it's that period of time that we need to make sure that there's no steroids in your bloodstream. We've reduced them, we've stopped the chemotherapy's gone because we don't want anything to be affecting these wonderful new T cells that we've just given you. We need also to have a couple of weeks in between radiotherapy as well. So that's why it's really important that we know about you early. At Westmead we have a wonderful lymphoma MDT, and I know that Concord and RPA do as well, and they discuss patients. So if we are thinking, oh, this is a very aggressive disease, we might be heading out your way, then we have a discussion about what sorts of treatments might be happening before, so that by the time you come to see us, if you're needing to have CAR Ts, then we're not having to wait several weeks for that bridging period to happen, for that washout period to happen. Bridging therapy requires a lot of complex discussions quite often between the CAR T cell centre and the referring centre. Some people may not need it, other people may. Now, we don't want it to be really aggressive chemotherapy because we're not trying to kill the lymphoma. We know that we can't. That's what we're getting the CAR T cells for, but we want to temporise the disease so that it doesn't explode in that 17 to 28 days and we can't control it with a CAR when they're there. So just something to temporise the disease. So it is a a big discussion point these days, to make sure that we don't give something that is too aggressive, so that you come to us and your bone marrow has been affected and you've got no platelets, very few white cells, and you're red cell dependent. So we want to do something that's on the disease but not too much. I've lost my words, but doesn't affect your marrow too much. So the lymphodepletion is routinely cyclophosphamide and fludarabine. It's only 3 days. Very small doses, just enough to get rid of the T cells. And some people need to have bendamustine if they have other comorbidities. It doesn't suit them to have cyclophosphamide. And then we have a couple of rest days. So the CAR T cell workup, so you'll have loads of contact with our CAR T cell coordinator. She'll be organising a blood test. You need to have a lung function test because we want to make sure that your lungs are good. Kidney function test, because if you can imagine, we're giving chemotherapy, then we're giving CAR T cells, we're killing a lot of lymphoma. We need to make sure that your kidneys are okay for that lymphoma. We don't want to be doing any more damage, and we don't want to have damaged kidneys already. You need to have a PET scan. You might require other scans. If there's lymphoma in your brain, then we'll need to do an MRI so that we can make sure that that's under control. And some people have disease in their marrow, so we need to do a bone marrow biopsy as well. So the cells arrive back at the centre, and they're stored at minus 190 degrees in our laboratory, and that's what they're transported at, minus 190 degrees. Lymphodepletion will start when they're in the lab. Sometimes if people's disease is really taking off, we know when the plane left and there's not going to be an earthquake anywhere, or there's not a volcano, then we'll start lymphodepletion while they're in the air. And then we'll have the reinfusion of the CAR T cells. That's normally about 10 to 15 minutes. That's all it takes to be reinfused. And sometimes if it's a very small volume, we might just use a syringe driver, and that will go over in about 10 minutes as well. So -5 to -3, yep, okay, so day 0. So before you have your cells, we'll do your vitals. And then we do a baseline ICE score, which is immune effector cell encephalopathy score. So we want to know that you know where you are, what day it is, what state you're in, naming a few objects around the room, following commands like close your eyes and hold up your right hand, attention, counting in tens from 100 back to 0, and then a handwriting, and it's not a test. You can be as messy as you need to be. What we look for over the next 30 days is that there's no change to that handwriting. So, you can say, I really miss my family, or I hate hospital, or I love my dog. And then that will be the sentence that you write every day for the next 30 days, and we have a look at that. The things that we're looking for is changing in the writing, staying within the lines, things like that. So during the infusion, so like I said to you, free flow, 10 to 15 minutes, or a slow push, and this continuous monitoring. So they'll have a heart monitor on you. The girls will do a blood pressure before and after, and then you'll be monitored for the next couple of hours. So the morning, you're either seen by the medical staff or myself. We make sure that you're satisfactory to proceed, and then pre-med is given. So it's usually a paracetamol and an antihistamine like Claritine, and that's normally about half an hour to an hour beforehand. And then we put up 2 lines. So one line is for the CAR T cells, and the other line is for if there's any toxicities, and we need to give you some drugs to fix those. And then we have a checking procedure. That's what it looks like. It's a little bit boring, isn't it, after all of that? About 68 mils in there. So 2 lines, 1 line in case there's any toxicities. There's your CAR T cells there, and there's another lot of saline on a Y beside it. So once this has finished, We then put a clamp on down here, put about 50 to 80 mils of saline in there to wash it out. We want everything out of that bag, don't want any cells left. Or sometimes we might give it as a push dose. So vitals every half an hour for 2 hours. Now the vitals are, you're not going to react to the cells, but you may well have a reaction to the DMSO, which is the preservative which the cells are held in. So it helps to keep them alive when they're being frozen, and then it helps to keep them together as they're being thawed so that they don't crystallise and break apart and die. So that keeps them together. Everyone can have a reaction to any drug. There's a very minuscule amount of DMSO in there, but if you're going to have a reaction, then we need to be aware of it. Things like racing heart, a drop or an increase in blood pressure. People can get fevers, and they can get rigors and shakes. And that's only, like a couple of mils, but it's enough to cause a reaction. So we keep a very close eye on you over the first couple of hours. After that, anything that happens is nothing to do with the DMSO and everything to do with whatever's happening with the CAR T cells. So then we go back to our usual fourth hourly, and then we do the ICE score that I just talked to you about. That's twice a day until we have some toxicities. And blood tests, sometimes we might have to do them twice a day, but it's good if you have a central line in, although some units do prefer to take blood peripherally. So it'll just depend on which hospital you're at, whether you have a central line blood or not. Toxicity risks, amount of tumour burdens, how much lymphoma is around in the body, and how much is going to be killed and being passed out through your kidneys. How many lines of chemotherapy have you had? What sort of long-term steroid use, and what sort of immunosuppressive treatments? If you've had a lot of previous infections, there is a risk of some of those coming back. Cytopenias, so that's when I'm talking about the low hemoglobin, your low platelets or low white cell count. And then also the intensity of the bridging program. And then toxicity can happen later on if you've had quite a bit of CRS or ICANS. So, early toxicities, tumour lysis syndrome, so that's as the cells are dying. If there's a lot, then they've got to come somewhere. They've got to come out somewhere, so they're going to come out through your kidneys. So we need to make sure that we support you through that. Cytokine release syndrome, ICANS or immune effector cell neurotoxicity syndrome, and bacterial infections as well. Now the ones after you're discharged up until 30 days, we're looking at low hematology counts. We look for bacterial infections, viral reactivations. Sometimes people can be at risk of fungal infections, especially if you've had a lot of pre-treatment. And as Janlyn was talking, B-cell aplasia, your B cells are targeted. There's going to be none of them around. You're at risk of all sorts of infections from that. And hypogammaglobulinemia, which we look at your immunoglobulins. If that's another part of your immune system, if they go low, then we can replace that as well. And then late toxicities. Some of these go out over 30 days. Some people can be needing support up to 6 months. So tumour lysis syndrome, if there's a lot of disease post-CAR T cell post the chemotherapy or post the CAR T cells, this can happen within a couple of hours. And we look for high potassium, high urea, and high phosphate in your bloodstream. So we'll be taking those bloods. If we think there's a risk, we'll take them twice a day. But what you might feel is some abdominal discomfort, some nausea, some vomiting, urinary symptoms, like you might be going to the toilet a lot because we're giving you a lot of fluid, or there might be some burning. And some people can get some muscle cramps as well. Occasionally, people can get cardiac arrhythmias, and there's a potential for injury to the kidney. So that's why we make sure that your renal function is good to start off with, and that we give you medications to protect your kidney during the chemotherapy and post the CAR Ts. Cytokine release syndrome. So this is a inflammatory syndrome, and it is triggered. Oh golly, sorry, it's triggered by the inflammatory cells that are released by the CAR T cells and the body. So the cytokines are released when the CAR T track down those T cells. They track down those cells that have got the CD19 protein on them. So whether that's a lymphoma or whether that's your native B cells, and when they attack those and they kill them, these cytokines are released into the bloodstream. And depending on the amount of disease, this could happen within sort of 12, 24, 48 hours, or it could happen up to 3 to 7 days post the CAR T cells. Fever is majority of the time going to be your first sign. Body aches, shivers, shakes, an increased heart rate, drop in blood pressure, some shortness of breath, and drop in oxygen levels. Now, sometimes this increased heart rate ends up being an abnormal rate that we need to get people to, cardiology people, to have a look at you. And sometimes there's that fluid shift that Janlyn was talking about from your vascular system out into your tissue. Doesn't matter how much fluid we give you, we're not going to be able to replace that. And so assistance may be required also for breathing. And that's when we would have the support of our intensive care unit. Now, CAR T cell centres do a lot of work with the intensive care unit, and they're aware when our patients are having their CAR Ts. If any of you have been in hospital before, you might have heard of a code blue, and there's a lot of code blues on the CAR T cell. We have the intensive care people coming to look at our patients a lot. It doesn't mean necessarily that you will go there, but we have their expertise to put with our haematology expertise to see the best care for you at the best time, and then they're aware of you. So if we have too many code blues in a day, they think, this is not right, we need to keep a much closer eye on you, so you come down to the intensive care unit. Now, that doesn't necessarily mean really bad things are going to happen. They may just need to keep a much closer eye on you. They might need to give you some drugs to keep your blood pressure up, might need to give some high flow oxygen to keep your gassy exchange properly and keep that oxygen getting into your lungs. Really, some people might need to be intubated, but majority of the time that we send patients to intensive care, it is for monitoring, it's for blood pressure support, and it's for replacing of electrolytes as we need them, things that we can't do on the ward. ICANS, or immune effector cell associated neurotoxicity syndrome. This is our second most common early adverse event of CAR T cells, and it occurs majority of the time when you've got CRS. If you've got severe CRS, then you're likely to get some sort of an ICANS, but sometimes people can get ICANS and their CRS is already cleared up. Most often happens about 4 to 5 days post your CAR T cell infusion, and the incidence increases with the amount of disease, with your age and the product that's infused. And it's caused by a cytokine-related disturbance in the blood-brain barrier, like Janlyn was saying before. So the blood-brain barrier normally sits like this, and very few things cross it from the bloodstream into the fluid around your brain. But when you have these extreme amounts of cytokines released in your bloodstream, they cause that capillary leak in the vascular system, but they also open up the barrier between your bloodstream and the fluid around the brain. And so cytokines get in there and CAR T cells get in there, and they're not normally meant to be in there. So they can cause problems. So normally median onset is 4 to 5 days, and the duration is can be up to 17 days. Now, I've missed a whole line there, so we don't go down to extreme ones, but things like headache, a bit of confusion, not being able to write your sentence properly. So I miss my family might just become a squiggle. And then we get on to a little bit more serious, where I can't recognise my loved ones properly, or I may not be able to speak. Things like that can happen as well. we keep a very close eye on our patients at this time, because sometimes people can have a problem with their airway. So if that happens, that's another code blue, and that's straight down to the intensive care unit, so that the guys down there can keep a really close eye on you. Doesn't necessarily mean that people need to have a tube down their throat to help them breathe, but we do need to keep a very close eye on that. And if people get severe ICANS, we make them nil by mouth, so they're not having any risk of eating or drinking and aspirating something. So other things it gets out as bad as Janlyn was saying before, seizures and a coma, but that's right down the other end. So CRS occurs in about 50 to 90% of patients, and severe CRS is about, real world now, about 10%. The CRS that we say 50 to 90%, that sometimes could only just be a fever. So you feel rotten and have a fever for about 3 or 4 days on the ward, and that's it. ICANS occurs in approximately about 10% real world now, and that could be just a little bit of confusion, not being able to write properly for a couple of days, or having word finding difficulties. Rarely these can be fatal, but very rarely. Other toxicities are our hematological toxicities, so we've got anemia, reduced white cells, and reduced platelets. We expect a B cell aplasia because, as I said to you before, the B cells have that wonderful CD19 protein on the outside, and so anything that's displaying CD19 is going to be attacked and killed. So you're going to end up with no B cells. Hypogammaglobulinemia, that was something I talked about before, that's the immunoglobulins. Some people can drop down quite low, so we need to replace those. And viral reactivation. Now, there's lots of weird and wonderful viruses. We keep a really close eye on them for the first 30 days, and as long as none of them have reactivated, then when you're back to your own centre, you won't need to have those blood tests monitored. Some people might reactivate some of them and need drugs for those, but I won't go into that now because it's a whole other ball game. And extreme fatigue, and I wanted to put that in there because I tell my patients all the time, you're going to feel fatigued, you're going to be exhausted afterwards, but it's not actually until afterwards that they actually realise it's this bone-weary tiredness. And why am I exhausted? Why can't I get up out of bed? So you go home at day 10 and you're feeling pretty good. By day 15, I'm like, oh my God, I can't even walk across the road properly. And that can go on to day 30 and sometimes out to sort of 2 months after the CAR T cells. It is very, very common. And yes, you're going to have a nana nap in the afternoon. And yes, you're going to have to force yourself to get up a couple of times a day, wander around the house or out to the front, down to the bus stop and back again, just to keep those muscles working. But it will get better. So what do we do to recognise these toxicities? Okay, so, oh, golly. Head to toe assessment every day in the hospital. We do 4th-hourly vitals. If we're concerned, then we'll be doing them more often. And sometimes people don't get a lot of sleep when we're concerned about them. Once or twice daily bloods. Majority of people have once a day, but if you're having quite extreme side effects, we like to keep an eye on what's happening with your bloods. So we look at the haematology bloods, the kidney, the liver function, and the inflammatory markers. Twice a week at Westmead we do CAR T cell enumerations, and I know they do something similar at RPA. I'm sure around the rest of the country it's similar as well. The neurological ICE score that I was talking to you about, so that's done twice a day until we have a symptom like a fever, and then we will do it every 4 hours with the vitals. We are very mindful of other adverse events. You're very immunocompromised, so really we need to check that it's not actually sepsis. So it's not a bacterial infection that's happened. So everybody, when they have their fevers, will have a blood culture, and we check to see, and we will start you on some antibiotics as well. And we get our ID people to have a look. And then post-discharge we do blood tests, and people are seen 2 to 3 times a week up until day 30. So the management of the toxicities, steroids and immunosuppressive drugs to manage neurotoxicity and CRS. Now, I'm not going to go into all of those, but if you can imagine that where you've had your CAR Ts, then we're giving you steroids for a week, then we're giving you all these other immunosuppressed drugs, very, very immune suppressed for months to come. So it's really important that you look after yourself, stay away from sick people, and take the medications that we tell you. So filgrastim, to manage neutropenia, so it's your GCSF. You've probably all had injections like that. You'll be having those. Sometimes it might start off being every day in the first week, and then we can nurse it out to being once or twice a week to keep the neutrophils about 1. So we don't want you to get any bacterial infections. Transfusion support, so lots of people need platelets out to day 30. Some might need them even longer than that. Antifungal drugs, antibacterial drugs and antivirals are really important. Now, the antiviral medication might go out 6 months to a year. I often get phone calls, do I really need to be on this? Can I stop now? Then I have a look at the bloods and I go, right, let's walk through them. Have you got any B cells? Oh, no. Have you got any neutrophils? Oh, well, I'm still having GCSF twice a week. Well, then, no, you can't stop the antivirals. Sometimes if we know with the filgrastim and we can keep your white cells at 1 and they're not dipping down, we can perhaps stop the antifungals, but that's in conjunction with your referral centre. So immunoglobulins, we'll replace those like I said before. Now, if people have had ICANS or if they were at risk of ICANS, they'll be on anti-seizure prophylactic medication, and that has to continue out until day 60. And then we wean it in conjunction with our neurologist. We have a CAR T-cell neurologist who works at Westmead, and he will let us know what he wants individual patients to happen, and he might see or do a phone consult with you afterwards at 3 or 6 months. And no driving for 8 weeks. As Janlyn said, you must have a carer, must stay within an hour of the hospital. So if you're outside our hour, then you will be staying in a local hotel somewhere. And that's when I said that the companies that provide the CAR T cells will pay for you to stay in a local hotel. So you're not going to be out of pocket for that. Like I said, most patients are discharged day 10 to 15. Clinic reviews 2 to 3 times a week with myself and the haematologist. Pathology will be twice a week, and then you'll need your filgrastim and your other supportive medications, plus or minus immunoglobulin support and transfusion support. And everyone, and it doesn't matter what hospital you're at, will have some sort of an ED, that's an emergency room referral put on. We're very lucky with ours. We have a really good keen ED physician, and if our patients present in that first 30 days, when the triage nurse opens up their name, a triage letter will come from him, not from us, but from him, because he's listened to more than we are, and then they'll do what he says, which is get you through quick. Return to the centre after day 30, and medical response. So that's after you've had your PET, plus or minus, might need an MRI or a bone marrow biopsy, and then you'll have that final discussion with the CAR T-cell doctor. Then we need to have follow-ups at 3, 6 and 12 months. Now they're mandatory from the government. We must follow you up at those times. Depending on where you go, you might be able to have your referral centre and your CAR T doctor work together, so you can have a phone consult. You must have a disease response, either a PET or a marrow or whatever it is that we're using to gauge the response. And then we sort of negotiate who you'll see and how you'll see them. At our hospital, we mandate that you must come back at 12 months because we want to lay hands on you and have a good look. And then it's a yearly review for the rest of your life. And we attempt to coordinate care really well between our referral sites and our centre. And we have, over the last sort of 3 or 4 years, got some really good contacts in each centre. So we have nurses that we contact and we let them know when you're coming back what sorts of things they might need to do. We get them to make your appointments so everything's set when you get home and you see your haematologist within a couple of weeks. And then long-term medicines may be required, just depending on how you're responding. Thank you.
Thank you, Karen, for that very detailed explanation of the practical aspects of CAR T therapy. We would like to welcome our last speaker up, Professor Judith Trotman. Judith is a Senior Staff Specialist and Director of the Clinical Research Unit in the Haematology Department at Concord Repatriation General Hospital. She'll be discussing access to treatments and understanding clinical trials. Thanks, Judith.
Thank you very much. I think it's about 5 years since I was Director of the Research Unit. I've passed that on to a young gun. Look, it's so lovely to see you all here. Patient education is our happy space. I am actually going to also introduce you, because I've dragged her from the clinicians' room, to Dr. Burton. If you wouldn't mind standing up, Kathy. We are so grateful we have got Dr. Burton over from the UK as our keynote speaker in lymphoma. At this ALLG meeting, and I said, come on into the room, the patients will love to hear from you. So she's under instructions to interrupt and add any extra value feedback about clinical trials as I speak, and she's got a good loud voice, so she'll be able to do that. So as a result of this session, I want you to feel confidence in clinical trials and not feel a sense of fear of being a guinea pig, but really understand that good clinical research that is conducted under the highest integrity in terms of science and ethics is deeply embedded into the advances that result in more cures and better lives for patients with lymphoma and indeed all blood cancers. I want you to understand why we do trials, what are some of the trials that are actually out there at the moment, and also we'd like you to become groupies with the ALLG. We want you to understand that we've got this great big cooperative group across Australia and New Zealand where all the teaching hospitals, whether they be in the cities or regional, are committed to the cooperative clinical trials research that addresses your priorities, and we welcome your feedback and engagement about your priority settings. So what is a clinical trial? And there is going to be a bit of science here. There has to be science because clinical trial is science. It's a very carefully designed study conducted in humans under the code of GCP. Now, what is the code of GCP? It's an international code of good clinical practice that ensures that you, as the participant in a clinical trial, have your rights and your safety and your well-being placed above all other considerations in clinical research. That is absolutely mandatory and core to good clinical research. So under the code of GCP, we seek to determine under controlled conditions, first the safety and then the effectiveness of a new treatment approach. And here I might just segue and ask you to put your hand up if you are aware you've ever been on a clinical trial. Only 3 hands. There's supposed to be 6% of lymphoma patients around Australia are on clinical trials, and yet we've got the most well-informed, motivated bunch in the room, and there's only 3 of you. Have any of you been on 2 trials? 2? Yeah. Well done. Congratulations to, well done. So thank you for your pioneering contribution, which adds to the advances for all patients. So we have them to improve treatment for patients. And here's a New Zealand Air Force pilot who was on a Hodgkin lymphoma trial for advanced stage Hodgkin lymphoma. And because of his contribution and the contribution of hundreds of patients, whether they were in Germany or Australia on this clinical trial, they established a new standard of care, dialing down the toxicity. Oops, I've done the wrong thing. Dialing down the toxicity of this escalated BEAR-COP regimen by adding a clever targeted therapy with less chemotherapy. And this study, of which Hemi was a participant, was actually published in Lancet, one of the leading medical journals, just last year. So it's there to improve treatments and outcomes for patients, to answer scientifically valid research questions. We also do use them. Those of us who are clinical trials zealots use them as a means of accessing new treatments for our patients, because the PBS is great, but the PBS is late. And it's many years often when a drug has been shown in early phase trials to be very effective before we actually get access to these drugs. So often we get access to these drugs that are available and utilised in the US through different clinical trials answering specific questions. Is this open for a reason? No, good. It's very distracting. There's lots going on out there. And obviously to improve knowledge to change practice. So, as I said to you, it's all about safety first, but once we've done the lab studies in different cell lines or little animal models, we then move on to what is called a phase 1 clinical trial. So it's very simple, 1, 2 and 3. Phase 1, where safety is number 1. You're testing very small incremental increasing doses of a new therapeutic agent, a new medicine, in a small number of patients to make sure it is safe to deliver. Now, some phase 1 trials will give a little signal of efficacy, the effectiveness of the agent, but the real priority of phase 1 trials is drug safety. And then after it's been shown to be safe, and after we've worked out what's called the MTD, the maximum tolerated dose, so it's a safe dose to give, we then test that in a larger cohort of patients in a phase 2 study. And any of you who have been on a clinical trial and have signed consent for that same clinical trial half a dozen times, that might be because that drug that has been shown to be very safe in a phase 1 trial has then moved on to phase 2 in the same clinical trial. And there have been lots of adjustments to the trial as more and more is known about the safety and efficacy of the drug. And that usually involves several dozen or hundreds of patients. And efficacy, gosh, wouldn't it be nice, Kathy, if we had thousands of patients in our lymphoma trials? It's usually several hundred patients in our large phase 3 trials. But some of our lymphoma trials, like the trials that demonstrated the efficacy of rituximab maintenance and the efficacy of obinutuzumab, were 1,200 patient studies.
Yeah, I think we achieved that with international collaboration.
We do, and that's a good plug for international collaborations, and we're particularly friendly with our UK colleagues at the moment, as you can imagine. Yeah. All right. Never give up on a crisis. And Brexit and the Trump effect has brought Australia and the UK very close together. Why do you think we've brought her over? And so, I've kept this cartoon in because I do like it. This is sort of the lab testing. So, we've done the study in the labs. Now, what are we going to do? So they follow a plan, and that plan is called the protocol. And the protocol is our Bible. No, I shouldn't call it a Bible, should I? Because we shouldn't deviate from the protocol except for one reason. Anyone like to give a reason why we should deviate from the protocol? Safety. Thank you. You are a really good clinical trials ambassador. Thank you, Simon. Safety comes back to that. Your safety is paramount. And so if your safety is challenged by following the protocol, we are allowed to deviate from the protocol, but with good justification. And that's often a reason why protocols are amended and there's there's a number of highly regulated processes. Once we think of a clinical trial, it might actually, start operating. You can tell me when you get it operating in the UK, Kathy, but it often will take like 2 years before it actually starts operating here in Australia. And I suspect you're probably a little bit faster in the UK.
But only by maybe 18 months to 2 years.
Yeah. So it does take a long time for the regulatory wheels to go through. And an ethics committee will always review both the science and the ethical underpinnings of the clinical trial before it's ever approved. And then, of course, the governance office and the lawyers are the ones who turn what should be a simple 2-page summary into a 30-page document. Okay, and it's very, very overwhelming for so many patients, but we do try in some of our trials to give a sort of an executive summary, and we also, in the ALLG, we have our consumer representative group who look through our documents and really try and make sure our patient information and consent documents are as simple as they can be. But the problem is, you're all so different, all right? Some of you want it simple on 1 page, and others of you will put red ink through all 30 pages and want to ask more. So we try and reach the happy medium. Yes, some of them are lawyers, aren't they? Oh my goodness. I've got to say, Kathy, I should speed along, I promise. But I work out at Concord Hospital, but I trained at St Vincent's. Who's a patient at St Vincent's? Because I don't want to offend you too much. But you know what? You're a pretty high maintenance bunch, aren't you? Okay? And then I came to Concord. Who's at Concord? Oh, good on you. So yes, right. So Concord patients are great patients. They put a lot of trust in you, and they ask some very sensible questions, but they don't come with 3 pages of questions filling up my public clinic. I don't know. How are the patients in Leeds, Kathy?
Leeds, but they're very obedient.
They're very obedient. Yes, Concord patients are very obedient too. But, it is that nice sort of balance between, balancing your deep, intimate knowledge of your own body and your own disease, which you may have had for 10 weeks or 10 years, and your Google search, which may have been for many hours, and my 30 years of clinical practice. But we get there in the end. Okay, so the clinical trial team is not just your doctor. All right, you have a whole army of people behind that doctor, your clinical research nurse, your study coordinator, and I call them your study concierge, because they are there to make sure you do the right thing at the right time, and that I do the right thing at the right time, and that you get hold of me when you need me fast. All right, so they're really there to help you navigate the whole clinical trial journey within the health system. And that is sometimes the best advantage of participating in a clinical trial, even when you're receiving what might be standard of care in the clinical trial. Because we actually didn't talk about phase 3 trials, I'm sorry. So phase 3 trials is what we call the randomised clinical trial, where we compare we compare the standard of care treatment, which might be rituximab and CHOP, with the new proposed treatment. So one message I want you to go home with today is we never randomise anyone to a placebo unless the standard of care is observation. So that might be looking at rituximab treatment as a sole treatment for your follicular lymphoma compared to watch and wait observation. Okay, so please don't ever think that if you're participating on a clinical trial, you're going to be given a placebo instead of treatment when you should be having treatment for your disease. So that's the clinical trial team, and we will assess your eligibility. And we will start the screening and informed consent process. And it's not a one, and I'd love your reflections on this, Kathy, it's not a one-stop thing, the informed consent process. We don't talk to you about the trial and then get you to sign the 30-page consent form there and then. It's an iterative process, sometimes ideally over multiple appointments as we start thinking that a clinical trial might be appropriate for you. You cannot possibly expect to understand everything there is to know about a clinical trial, in one consultation. And even when you do consent to participate in the trial, you're going to be learning as you go about the clinical trial. So don't feel too anxious that you don't know all the nitty-gritty about when you have to be on day 4 and day 5 and how many blood tests you need to have over the next 3 weeks and all that sort of thing. Your clinical trial coordinator or nurse will take you through that process. I think what the most important thing is feeling that you can trust the team. You've read enough about it, you've learnt enough about it to feel, yep, I'm ready to jump in, and trust that the team will tell me if there's going to be any changes to the protocol. Any further comments there, Kathy?
I think we do similar. I think with the screening, sometimes if we know a trial about the agent but isn't quite accurate, you can't actually give out the patient information sheet. But then sometimes we send them out to patients so they have the opportunity to before it comes to clinic. And I think the point you make is talking to the whole team. It's not just the doctor, it's the nurse, the trial coordinators, because I think they've often got maybe slightly different perspectives on the trial.
And the nitty-gritty requirements, because when you go through the consent process of the trial, you're going to tell them about what I call as sort of the PPRV, the purpose of the trial, the procedures that are required to be done, and then the risks, the potential risks of participation. There are always risks to participating, even if it's only, risk from a car accident on the way to too many hospital appointments, and the alternative options for you if you were not to participate in the trial, and the fact that it is voluntary at all times, not just the moment you sign the consent form, but that you can pull out of the trial at any time. And I think I might have a slide about this. I haven't done this for a year, so I can't remember it's a bit lucky dip what slide is coming. So during the trial, you're going to be monitored very carefully, and there is one extra burden of participating in a clinical trial. All right, you will, generally speaking, get more blood tests and more clinic appointments than you would in your routine day-to-day care. We try and limit that so that it is not too burdensome, but we have a duty of care, not just to you, but to the integrity of the study and making sure the data and the safety is paramount. And then once the clinical trial has completed recruitment and it's got its 300 or 1,000 patients, it will often take another year or 2 or even 5 years before the results of the clinical trials read out, before you've got enough follow-up if your primary endpoint is survival or duration of remission, or what we call progression-free survival for some lymphomas where relapse is a potential risk.
I think that's a really important part of the point, isn't it?
Nice and loud, thanks, Kathy. We've got a phone. Let's give Kathy a microphone.
I just think,
in terms of the feed out from trials, it often is 2 or 3 years later, but what's really nice is then to be able to share some of those results with patients that have been into trials. So I really try to do that if I've been to international conferences and just say, look, the trial you were in has just reported out, this is what it showed, especially if they've been on the correct arm, the beneficial arm, that's always easier. But I think patients really feel then, it's really good feedback that you've contributed, that it's been a big, international trial, which it quite often is, and that, that's the output from it. So I think it's good to be able to share that.
I think those lay summaries are so important. I'll tell you a lovely story. Sorry, I'm getting into trouble from getting the evil eye from Kate here. We participated in Australia, and I was sort of leading the Australia and New Zealand contingent in a study called the Rathel study, which was a study of response-adapted therapy in Hodgkin lymphoma, where we were using the PET after 2 cycles of chemotherapy to sort of dial down the chemotherapy for patients. And this was led by Kathy and her colleagues in the UK. And we were so excited about the Rathel study because it had been accepted for publication in the preeminent New England Journal of Medicine, which is, the top journal of medicine. And we were so thrilled. And I said to Peter Johnson, come on, we've got to do a lay summary and we've got to be ready with our press releases. So I was busy writing lay summaries and press releases because he's not a PR kind of guy. So anyway, we did this and we released it all on the day of the Brexit vote. So I always remember when the Brexit vote was, Kathy, because we got zero interest in the Rathel study. And all the years and years and the hundreds and hundreds of patients who had made their contribution to reducing the amount of chemotherapy for young and old with Hodgkin lymphoma went by without a whisper. But it still made a huge, important impact on people's lives. And all the Hodgkin studies that Kathy has led since then have iteratively improved the safety, dialed down the toxicity, and improved the efficacy of our treatments for Hodgkin's. So because of trial after trial after trial, the vast majority of patients with Hodgkin lymphoma are cured and living well after their treatments. It's a really exciting time to be a lymphoma doctor. So, here we go. Here's my sort of memo about... let me go back. Oh, no. You've got a lot of faith in me if I can't even manage a PowerPoint pointer. So I remember my PPRP, the purpose, the protocol, the risks of participation, the potential benefits, because we can't guarantee any benefits, all right? It's always potential benefits, the alternative treatment options, and the fact that it's voluntary, and the assurance that if it's no longer, and this is something that's really important for me to stress to my patients, the trial, I'm offering you participation in the trial because I believe it is the best thing for you. And if I ever believe that your continued participation in the trial is no longer in your best interests, I will be telling you to withdraw yourself from the trial. And that sometimes is a little bit confronting for some patients when we have to change tack and stop trial participation. And obviously the patient has to be competent of documenting consent or their surrogate. So why do patients consent to participate? Because of the direct benefit from them. They want to get their hands on that new emerging therapy. Because there is some data, it's not hugely robust, but there are definitely some data that suggests that if you participate in a clinical trial, your outcomes are better even if you're receiving standard of care. And it's probably related to that concierge, making sure we're all doing the right thing at the right time, at the right dose, and etc. And obviously for altruistic reasons. And I'm so amazed at how many people, and some people I also treat acute leukemia where the prognosis is not nearly as good as it is with most lymphomas. And some patients will participate in clinical trials that are dose-finding trials that they know probably won't help them, but they want to advance things, medical science, for the patients who follow after them. And so, the sense of being a pioneer is really important, and that paying it forward for other patients. Because, all those rituximab trials, imagine if we didn't have rituximab to treat B-cell lymphoma, if we didn't have those trials 20 so years ago. So the benefit to medicine and science and to future patients is very important. Why wouldn't you participate? And it's very important because I have some patients say, no, I'm not going to be a guinea pig. I'm not going to participate in a trial. I don't want to hear about it. And I say to them, well, okay, but just as informed consent is very important, so is informed dissent. So I want you to listen about the trial and understand why you're saying no. It might not be the right question for you, and that's absolutely fine. The risks might be considerably, the balance of the risks might be unacceptable to you, and that always must be acknowledged and quantified as best we can for you. For some people, it's just easier They don't have to think about another thing when you're faced with this new diagnosis and dealing with the treatments in the hospital. You've never been in a hospital before. Dealing with all those things, dealing with the clinical trial and the paperwork and the extra bloods and the protocol is just one thing too much. They want to keep it simple. And that's particularly relevant when patients are newly diagnosed, particularly if they've got an aggressive lymphoma and we're clipping along. We need to get started on your treatment pretty quickly, and it is sometimes considered just too onerous. And so that's really important to appreciate. There are reasons why you shouldn't participate. So just a little bit about us, the Australasian Leukemia Lymphoma Group. We are a binational. I hope you've picked up the Kiwi accent, all right. We are an Australian and New Zealand cooperative blood cancer trial organisation, and we've got 1,400 members who are all volunteers. We've got this amazing staff of 30 or 40 now, isn't it now, Kate? This amazing organisation of clinical trials operations staff at the ALLG. But all the haematologists, all the scientists, the pharmacists, the nurses who do this because they believe in investigator-initiated research that is focused on your priorities. And we all love participating in industry clinical trials, all right? Industry are the ones who have the good drugs, and we love their trials, and we love getting access to their drugs. But we also like our trials where we repurpose their drugs, or we tweak things so that it leads to not just better treatments but better lives for our patients. And so there's a really important sort of symbiotic relationship that we have at the ALLG with our pharmacy, with our industry partners, and some of their trials, we'll all participate in clinical trials in our own hospitals. And some of the times they will help sponsor and fund. Sorry, they won't sponsor, but they will help fund and partner with us in our clinical trials. Because, industry partners, wouldn't you agree? You can't do all trials for all people. And so sometimes the cooperative groups around the world have to provide those complementary studies. And it's not-for-profit organisation, and we're a registered charity. And go back to your own doctors and say, are you an ALLG member? All right? If you can do one thing for me, go and ask your treating haematologist, are you an ALLG member? Because I've been to the ALLG symposium with Lymphoma Australia, and I'm pretty wowed by all the stuff they do. And is that the end, Kate? I can't remember what else I had. Oh, all right. So this is just a bit of blurb about the members who design these trials, and each one of these people is a lead of a different group within the ALLG. And since we're at a lymphoma talk, I'll point out to you Professor Michael Dickinson and Gareth Gregory are our lymphoma group chairs, and Stephen Opat, the chronic lymphocytic leukemia chair. This is one patient who celebrates his 70th with chronic myeloid leukemia. My patient Brian, he's been on his he was on his clinical trial almost 20 years ago, in a time when we didn't think we could cure chronic myeloid leukemia, and now he's off drugs and cured, and never thought at the age of early 50s he would celebrate his 70th. And I don't need to see him in clinic anymore, but I get him to come back once a year to make me feel good. Okay, we need to feel good. Doctors need the good vibe. You have a few you keep coming back to, you, Kathy, do you, for the vibe?
You have your favourites, don't you?
Yeah, you have your favourites. All right, so inform yourself, all right? The ALLG is only a Google search away, okay? The Lymphoma Australia have so much material online about clinical trials. Always ask your treating haematologist at each stage of your journey when you need to have a new treatment, is there a clinical trial I should be screened for? Now you notice I didn't say I should be enrolled for. All right, screening. Screen everyone and enroll some. Okay, because not every trial is the right fit for every patient. And so screening is what is absolutely central. And Kathy, they want you back. But thank you for coming and adding your commentary. We're winding it up. There you go. That's, no, we don't need all this stuff.
Yeah.
Lots of stuff on the internet now. But ask your treating doctor. Yeah. Questions. Are we doing questions now? We're doing panel. What are we doing next?
We are going to invite our speakers back up the front.
Great.
If Judith's finished.
You can leave that up there, Judith.
Can I
that's fine.
promote ClinTrial Refer? Go to the App Store, download ClinTrial Refer, because ClinTrial Refer Haematology New South Wales has lists of all the currently recruiting clinical trials. All right? It doesn't list trials that are closed to recruitment, or it shouldn't. So you can search your particular disease.
Make yourselves comfy on these
All right.
big chairs. Yeah, sorry. Slightly terrifying chairs.
All right. So, Kate, are you going to MC this, or you want?
No, Liz is going
Liz,
to. So
Liz,
Judith will
good
get
on
to
you.
take
I'm
a
going to
seat.
join and take a seat.
Share those if that's okay.
Shall we move?
Yeah.
So it's not in your eyes?
That's better.
What did you get?
Thank you, Judith, for that. So we're just going to throw out to our audience, and just if you can raise your hand if you'd like to ask our 4 expert panellists the question. Yeah, just down the front.
I just wanted to ask Janlyn whether...
Just try and swallow the microphone.
Oh, okay. Just wanted to ask if there was any specific criteria to receive bispecific antibody treatment.
Yeah, so at the moment in Australia, there's a recommendation for PBS listing for one of the antibodies for patients with diffuse large B-cell lymphoma who've had 2 prior lines. For the vast majority of other bispecific treatments at the moment, most of that is in the context of clinical trials or patient access schemes. So certainly, as Judith has highlighted, the importance of checking with your clinician about whether there are some trials that utilise bispecific antibodies. And at present, there are certainly some for follicular lymphoma, off the top of my head, with one of those bispecific antibodies in New South Wales at the moment. So in terms of the criteria, there may be some utilised earlier in treatment as compared to those for patients who've had prior lines of more conventional therapies. So clarifying and working out whether you might be eligible to be screened is really important.
Hi. CAR T is currently offered in 2 centres, RPA and Westmead. Is it anticipated it will come to other hospitals or other treatment centres? And what's the sort of time frame they might be planning on that?
Thank you for your question. I think I can answer that. So the other 2 hospitals coming online immediately are Royal North Shore Hospital and Liverpool Hospitals. They're coming online in the time frame of months, like a short number of months. And I think Concord Hospital is another hospital very interested to...
We don't, but we'd like to do clinical trials, and we're going to be doing clinical trials in autoimmune disease. So you don't come to us for your lymphoma CAR T. But thank you, Koon.
Yeah, not at the moment. But anyway, maybe in the near future, because we're seeing a lot more increased work. So yeah, good question. Thanks.
A question to Dr. Lee. Now, you mentioned that CAR T cell that possibly that could kill all the other cells. Now, is there any new drug that could reverse CAR T cell if that takes place?
Oh, thank you. So the side effects for CAR T cells sometimes can get out of hand, and we do have certain specific medications to mitigate those side effects. One of them is an antibody against the cytokines, which Karen and Janlyn actually talked about. So that's called tocilizumab. So that's one of the things that we can mitigate that side effects. The other things that we do is giving high dose steroids, and that can actually kill or stop the CAR T cells from from proliferating too much. And of course, in terms of specific design drugs to kill the CAR T cells, the ones that are available commercially, they don't have a kill switch, but there are a lot of other CAR T cells in research trials that have got a design kill switch in them, where you can give a drug that can completely eliminate those CAR T cells.
I specifically have the TP53 deletion in mantle cell lymphoma, and my understanding right now is that CAR T is third line when the first line is chemo with stem cell. I'm wondering if that's still the protocol here in Australia, because I know in North America that's slowly being seen as not being efficacious. And so just from a personal point of view, I'm wondering whether or not if I decline stem cell, whether that would mean I no longer have access to CAR T.
Would you like to take that?
No, you go ahead.
Okay. So look, the criteria for mantle cell lymphoma does not require stem cell transplant, and you're quite right in saying that it is becoming an active area of research about whether or not stem cell transplant is necessary for all patients in mantle cell lymphoma. That's, we have got a lot of data coming out about minimal residual disease to show that some patients not going through transplants can do as well as patients who actually go through transplants. So yeah, to answer your question about eligibility for CAR T cells, no, you do not require a transplant to have that. The wording is, saying that you need chemotherapy as one line and a BTK inhibitor for the other line. So it does not need to have a transplant.
Okay. Can I ask a question following on? If you've had stem cell, do you still have to do the BTK?
To get access, yes. For CAR T, yes. For the MSAC CAR T.
But I think if you're on a BTK inhibitor for your mantle cell, and if you've got a particularly, concerning deletion like TP53, your hematologist will be monitoring you very closely for progression or failure to reach certain milestones, so that they're ready to switch to things like CAR T cells earlier. Could you expand on that, Janlyn, do you think? Is that a fair enough?
Sure, yeah. I think you've outlined that well, Judith. I think particularly if we're learning more and more about the contribution of certain genetic or molecular tests to help us understand across the board with lymphomas how diseases may behave, be it more aggressively or a bit more indolently, and how that shapes not only how we treat you but also how we monitor you. And certainly for patients with, as you say, more aggressive disease, or in fact really anyone who has mantle cell lymphoma in second-line therapy, we know from a pattern of how long BTK inhibitors tend to be effective that particularly, as you head into that 18 months, 2 years on therapy, we tend to watch you like a hawk. And even more so if you have certain genetic factors or changes that make us a bit more suspicious that you might be heading towards your third line sooner.
I just quickly add as well, the treatment of mantle cell lymphoma is becoming a lot more nuanced these days. So with TP53, certainly that involves a lot of discussion between you and your treating hematologist. CAR T cells, unfortunately, it seems like those long-term data is still showing that some patients are still relapsing as time goes on. So whether or not it is the absolute right thing to do it as soon as you can get access to CAR T cells, it's worth a discussion.
Can I also make a comment? Sometimes in Australia you will be treated with something that you wouldn't be treated with overseas, because we don't yet have access to some of the things that have been developed. But we might be treating you with this to kick the can down the road for a certain period of time, for a year or two, while I can see that this other therapy will be on the horizon. And so, sometimes we're treating you, but not too hard, because we don't want you to have too much toxicity and not be eligible for the other treatment. So, this is where there's a lot of art as well as It's sort of like the art and the politics of treating medicine, isn't it? Dealing with, trying to keep... I say to my patients, it's my job to keep one step ahead of you every time, to have a plan B and a plan C and a plan D. But, also we have to be honest that, sometimes plan E is good, supportive, palliative care, and being honest with you that we don't have any other drugs up our sleeves, so that you can, we're all going to die. And unfortunately, if you've had relapsed lymphoma, that is going to be threatening to you a lot sooner than you otherwise would have thought. And it's really important that we are honest with you about our expectations. But isn't that just the wonderful thing about being part of clinical trials, is the number of people who prove us wrong, all right? Because they're getting some of these great new treatments. I mean, you must have seen that in your CAR T cell studies, yeah?
Yeah, absolutely. We keep getting surprised. So, there's always hope there.
Can I say something? I'm just wanting to know how long is the CAR T active for it? Because when I went into this treatment, my nurse practitioner said that the CAR T is like a Pac-Man and it chews its way through the cancers and that, but my cancer keeps coming and going, and I'm wondering if the Pac-Man sort of chew up the cancer and then go into hibernation, and then the cancer comes back and the Pac-Man chews it through again, and then the cancer comes back a bit later. And I have DLBCL leg type, and it's really affecting my legs. I feel like I've failed CAR T, and I've got side effects in my right leg that are quite painful and quite... I know there's a new CAR T on the table, but where I'm coming from, I don't particularly want to do
Thanks,
it.
For your question. I think the question about the CAR T, how long they persist in the body, it is interesting that we can see now with our patients, a lot of them having still a measurable number of CAR T cells even after a year in the blood. It's,
I'm at 6 months.
6 months is not uncommon to see still some circulating CAR T cells, but the lymphoma cells can be sometimes also quite sneaky in terms of, although there's still CAR T cells around, they might find ways to evade the CAR T cells, so that's a possibility. And so as Janlyn has spoken about this, there are also bispecific antibodies and other treatments available if your treating hematologist feel that you're progressing through this line of treatment. There's certainly other treatment options still available. And so I think
I just can't stand the side effects anymore.
And that's a really important thing, and thank you for being so open and honest about that. Our treatments do cause side effects, and it's terrible when the treatment is worse than the disease. And that's where that honest relationship and planning with your treating team. And often, don't you agree? I'd love you to comment on this, Karen. Don't you think sometimes it's easier for the patients to explain to their nurse than it is to their doctor about their intolerable side effects? Could you perhaps comment on that?
I think so. I also think that we probably spend a bit more time. These guys are rushing, like they're little Pac-Man. They're all over the place. Whereas I'm very lucky as a nurse practitioner that I can put aside that time. So I make sure that I have a good hour, if not longer, when I first meet people, so that we can talk through anything that is needed. And then when I see people as an outpatient, I spend a lot of time. And I think that's why, because I sit down and go, okay, I'll tell you my things, what questions have you got, and then slowly as we're talking, might take 20 minutes, and then all of a sudden, blah, 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 everything comes out. And it is because I just sit there, and I have time, and I don't rush people. And sometimes...
You're very kind.
Sometimes people who are waiting afterwards are not happy, but then they get that time as well. So I think that is why. And I want you to talk now.
Thank you. I really concur with what you just said. I usually call nurses the army of angels. And really when I say that, I'm not really exaggerating. And we're not taking anything away from doctors, absolutely, but nurses definitely the army of angels around all the patients. And really, thank you. I take my hat for you all the time. And
I will pass that on when I get back.
Yes. That quote for the ALLG and Lymphoma Australia.
I'll pass that on when I'm back tomorrow.
Now, I've got a follow-up question to the lady's question. I was going to ask the same question too. Now, what happened to the CAR T cells that you give it to the patient? They have a time frame to them, so at the end of 6 months or 12 months they explode and they go. And I mean, what happened to them really? Because I had my CAR T treatment at Westmead. I think Karen remember. Unfortunately, you weren't my treating doctor then.
Maybe.
However, it's been about a good 3 years plus.
Oh, right. Okay.
I barely survived it though, and thank you to Professor Judith, and that was the issue. The first question I asked, if there are any treatment to reverse it, because the CAR T was simply eating all my blood, except the cancer cells. However, I survived, and thanks to obviously all the professionals there and the service and the help from all the team at Concord and at Westmead as well. But I just want to know if the time frame to the CAR T cells that is given to patients.
You answer that.
Yep, I'll just quickly say, so the CAR T cells sometimes, it depends on which type of CAR T cells. The one that you received probably for lymphoma will reside, some of them will reside in the memory compartment. So there are cases where when the disease comes back, there's a chance that the CAR T might re-emerge and start to do their own policing and start to attack the lymphoma again, so hence keeping it in long-term remission. So that can last. We now have data for a few years now, and sometimes that can still happen. But sometimes that fails to happen when the lymphoma comes back too long after the initial infusion. Then sometimes the CAR T cells no longer there, and they are unable to reactivate and restart a clone and attack those T cells, attack those lymphoma cells.
Yeah. And if you don't mind, Simon, what you alluded to was what we call cytopenias in the medical world, which means Latin, cyto is cell, penia is not enough blood cells. And the transfusion requirements that some patients after CAR T require for months and months and months. And you're thinking, how come the CAR T's wiped out all my good cells, and yet here's my lymphoma back again? And CAR T's still a pretty blunderbuss tool, isn't it? We've got to get much better at targeting the lymphoma cells and none of the innocent bystanders that are so necessary to keep us alive. I just think, if you don't mind, Simon, also just using your example is another important thing to tell you all in New South Wales that we collaborate so closely together. You were sent to Westmead for your CAR T trial, and then when the lymphoma came back, we treated you while we were trying and waiting for a trial to open at Macquarie Hospital. And we sent Simon to have a bispecific antibody. It was a trispecific, wasn't it? A trispecific antibody at Macquarie. We're not even going to go there, guys. and you know, and again, that kicked the can down the road for years. So you need to know that sometimes your haematologist might say, I think you need to go across the bridge or down the road, because they really have your best interests at heart.
Absolutely, I couldn't agree more. And you know, I'm a witness to all what you just said, Doctor. I know you sent me home once, and then you know you called me the miracle man whenever time you see me. So really, thank you, and very much. You know, I can't say you know enough. Thank you to all the team, whether at Westmead or Concord. I mean, our hospital system, health system in New South Wales, it's absolutely AAA. And then you know I've got nothing to complain about that.
Do we have any final questions?
End with mine and this gentleman's here. Having fatigue and cytopenias at 6 months and that. I just wanted to know, because I'm getting a lot of transfusions, I'm having blood transfusions every week. Am I going to be having that for the rest of my life?
So things will get better, and yes, it's of course your experience with the fatigue and transfusion dependence now is a significant side effect, which is like 6 months down the track. Things will get better after a year. Things will continue to get better, but I have to say some patients take a long time to get back to close to their baseline. Some people never quite reach their baseline again, which is one of the things about CAR T cells that we're hoping to improve. But to do keep the hope there.
Keeps coming back as well.
And yeah.
I think. Thank you for coming today and sharing your experience, and thank you for telling us, you know, the sort of things that really do drive us to do better in our trials and our treatments. Thank you. Oh, there's one more. One more. I thought we were wrapping it up.
What's happened to them? Do you know whether that happens more in one type of cancer rather than other type of cancers?
No.
So like with CAR T cells, certainly different products and different cancers, they can have different side effect profile. We do know with CAR T cell, yes, it's very effective for a lot of patients, but we don't cure everyone. We cure about 40-50% of patients with diffuse large B-cell lymphoma. And the truth is that it's very, very toxic for a lot of patients. We send ballpark figure about a third of patients to intensive care. We have a lot of long-term toxicities, as you can see here. But in comparison with the other treatments, it is still on average better, which is why we offer them for the certain group of patients. But you're right, it's not the same for everyone. It depends a lot on your patient factors, such as the comorbidities, how much tumor there is going in, whether there's any infections at the same time, and which product particularly is being given. So quite a few factors to consider.
And sometimes we don't know.
Okay. And so hubby has CLL. So do we know anything about that then? CAR T and CLL?
Yeah, so with autologous, meaning using your own cells to make CAR T cell therapy, there are early studies looking at CLL, but some promising studies in other types of modalities as well. But probably just to add to what Koon has said as well, I think that's why it's so important when we are meeting people to consider whether they may be eligible for either CAR T cell therapy or bispecific antibody treatment. Part of that personalised discussion that we spoke about is so important, not only finding about the factors about you as an individual, as a patient, but also then knowing about the disease and the proposed treatments and how those all mix together in terms of being able to put forward our recommendation for what we think would be the best option, but also speaking with you as a patient about what's important to you in terms of potential toxicities and outcomes, because that's so important when we make that shared decision together.
Okay. Is it available for CLL as yet or not?
Not at present. No, not in clinical trials. Perhaps we could finish, and I know we do need to finish, but perhaps we could finish on a nice positive note for CLL patients. We've had so many targeted therapies. The tyrosine kinase the Bruton tyrosine kinase inhibitors, ibrutinib, zanubrutinib, acalabrutinib, and then, venetoclax and obinutuzumab. But, if someone has progressed on both those treatments, there is a fantastic new BTK degrader on clinical trials available in New South Wales. So if you're interested in hearing about that, come and talk to Janlyn or myself.
We don't know that one.
There are always great new therapies coming in CLL, which is why, to be honest, they're sort of leapfrogging ahead of CAR T cell development in CLL. Yeah.
All right. Thank you, everyone, for coming. We really appreciate it. Thank you for our 4 speakers. We hope that you've gained valuable insight into treatments that are available for yourself or your loved one. If we can just go back to the slide. So I just wanted to flag, we do have our nurse support line. You don't have to get up. We've got our nurse support line Monday to Friday and our email. If you want any more information or support, please reach out. And I will just mention on behalf of Kate and ALLG that they are interested in hearing more if you would like to be a consumer representative. Yeah. So if you just wanted to reach...
Or a consumer ambassador.
Or share,
You don't have to do any work, you can just...
Or even if you would just like to hear a bit more about some of the clinical trials that ALLG are running, we do have a couple of our nurse team as well around up the back, Kate and Karen, so please have a chat to them as you leave. There's also afternoon tea outside for you and tea and coffee if you'd like. You got a question? We've actually filmed today, so it will be put up on the Lymphoma Australia website in a week or 2.
Yeah. And we'll email everyone when it's available so you don't have to keep looking if you've registered. And I think that's it. Yeah. Thank you to our speakers. Thank you, Judith, Koon, Karen and Janlyn. Perfect. If our speakers cannot leave yet, we have a small present.